Sir needs no introduction. We all know he's the pioneer and legend of laparoscopy. I got trained under him, and he's the chairperson, Paul's Hospital, Kochi, and is the board member of, he was the board member of ISGE 2012 to 16, elected member, the Society of Reproductive Surgeons, ASRM since 1997, authored 2 books and contributed 41 chapters and books, published 50 papers in international journals, invited review articles, invited lectures, many live surgery workshops, webinars, given hands-on training like me to more than 1,800 gynecologists in gynecological laparoscopy, distinguished alumni award from Trivandrum Medical College 2019 and lifetime endoscopy empowerment award by Indian Association of Gynecological Endoscopies in IAG 2018. We welcome you, sir.
Thank you very much.
So
Good
we
evening,
have
my
our
friends.
next co-speaker, Dr. Dhivya Narasimhan. So she is the consultant gynecologist at Billroth Hospital, Chennai. Johnstone medalist, Madras Medical College. Her field of interest, laparoscopy. She got Best PG Award, Paper Award from Oxycon 2010, and she has done fellowship from Paul's Hospital, Kochi. So over to you, sir and madam.
Actually, I had come to Chennai 2 weeks back for the Apache, and I was in a doubt whether to come for this FOGCE conference. But I had attended the last FOGCE conference, and I was very impressed with the program. And today I was more impressed by the attendance and the type of lectures going on. So congratulations, Aruna and her team for this wonderful program. She has asked us to have a dialogue on cerclage, cervical cerclage. We know second trimester pregnancy loss is a big challenge to obstetricians. We know there is no clear-cut guidelines how to manage such a situation. And cerclage is very popular, comparatively easy procedure. And some of us little overdo this procedure. So our aim is, what is the current position of this procedure? And we have very short time. And Divya will give you an introduction how to go about by demonstrating, by enlisting 2 cases. And it will be followed by demonstration of few videos on vaginal procedures, abdominal procedures, which will combine doing it. Over to Divya.
So, sir, this is going to be more like a frantic calls. I have another mic, sir. So more like the frantic calls which we are going to have, like we friends associated with each other and I calling up sir in the middle of the night to get his opinion on whether should I do it, should I do the cerclage, should I take her up. So that's going to be the kind of discussion we are going to have. Nice to see such a packed audience. So it's going to be like a dam holding back all the liquid and all the liquor and the precious pregnancy. So once we think of laparoscopic cerclage itself, all the guidelines pop up and all the ISWAJ images of how to measure, everything pops up because in our practical practice during the, in the consultation room, we see that the entire family comes with a mixed amount of emotions. Like one of them wants to undergo a cerclage, the husband has a different opinion, and that's where these guidelines, you know, kind of help us to even counsel them. So this is what the latest Green Top guideline of 2022 suggests. I would always, before you raise the eyebrows at certain situations, because we might not accept that. So let's go to the bottom of the thing. Everything is at the discretion of the surgeon. I know that's what we do when we are with the patient. But these are the guidelines. When it is a singleton pregnancy and there are 3 or more previous preterm births, yes, go ahead and do it. They give it as 3 or more. I know practically we don't wait till then. And if it's a singleton with a history of a spontaneous, just one miscarriage previously, and now she has not yet gone to a gynecologist and gotten her history indicated cerclage, they suggest us to just serially monitor the ultrasound, look at the cervical length. And if it's singleton pregnancy with no other risk factors and someone has picked up a short cervix somewhere else, then they ask us to just wait and watch, nothing to be done. And when there are previous unsuccessful transvaginal cerclages, which we see a lot of patients nowadays, insertion of a transabdominal cerclage should be considered in such patients. At the end, they just give us one very nice thing, the choice of the cerclage, whichever one you want to do, high cervical through the vaginal route or through the laparoscopy. It's all at the discretion of the surgeon and whoever needs it. So, and also depends upon the expertise that we have available. So how are we going to measure is also important, because the measurement of the cervical length should be done with a good ultrasound, a good magnification, and the bladder should not be too full. I'm talking about transvaginal examination and assessment, and the magnification should be really good, and make sure that it is in the longitudinal plane and you're getting a proper length. You're not including too much into the isthmus portion, or not giving too much pressure to the cervix also with your vaginal probe, because that can, change the cervical length measurement. And we all know the tight T, which is the normal thing, which should be. And then the next level of dilatation would be your Y, when we are a little worried. And that's the time when we see most of the patients and we're going in and putting the cerclages. But in the middle of the night, we do get calls with this V and U sign where there is bulging into the vagina itself, and we are doing a rescue cerclage for these patients. So a very simple case, a 28-year-old patient who's had a previous painless dilatation and delivery at 24 weeks. Now she's at her 14 weeks. She's done with her NT scans. Sir, is there still a role for a McDonald's in this patient? Because this is the first time she's coming to us.
I think a vaginal procedure will be ideal, and
should we consider Shirodka for her, sir?
by principle, I think the cerclage should be as high as possible. And if you McDonald's is comparatively a very easy procedure. All of us started with that, and you need some more experience, little more experience for doing a Shirodkar. But if you are used to, I think Shirodkar may be a good option.
A lot of us are losing a lot of interest in the vaginal surgeries. I think we should, at least for this purpose, we need to learn a little more of vaginal, me too. And McDonald's, I think it's a standardized procedure where you place a purse string, but even in the McDonald's, make sure that it is placed as high as possible. And when we go into this particular patient, a 34-year-old who's had one previous 20 weeks expulsion in the first pregnancy, and then she's had a failed McDonald's cerclage in the second pregnancy now. Sir, would you feel that the laparoscopy method or the Shirodkar should be the better one?
I think it's quite obvious. Already McDonald has failed, and probably I will go an abdominal route, preferably laparoscopic one, rather than repeating the same vaginal procedure. Regarding the timing, what you asked, I think an interval cerclage will be easier for majority of us. And if you don't get that chance, then probably you have to do it during pregnancy.
So during pregnancy, which time would be the best to do this laparoscopic cerclage, sir? If you're going to do
12 to 14 weeks after excluding any anomalies or any abnormalities.
One doubt which everyone has is if we find an anomaly after this at 17, 18 weeks, we are doing an anomaly scan after that. What would we do to the laparoscopic encerclage if she needs a termination?
I think even though we do the cerclage reasonably tight, you will get enough space to evacuate probably up to 16 weeks. So there should not be any reason why we should do a laparoscopic procedure again to remove the cerclage. Or it can be done vaginally, but up to 16 weeks, there should not be any problem in removing the products of conception.
So that excludes the one important thing which we always think in our mind. What if she expels again? What if she has an anomaly? I think we should go ahead, do what is best for her, and then we know the answer for that. As we all know, there are certain prerequisites, a baseline CRP and WBC count to ensure that there's no chorioamnionitis, and making sure all the anomalies, the major ones, are ruled out, and there are no bleeding or contraction, and that is when we are going to do the procedure. So I got this short procedure, very good vaginal surgeons like Dr. Aruna and our chairperson, Dr. Rupalata, and all do a lot of modified Shirodkars. So here I got this from Dr. Jaiprakash Patil because I'm not a very good vaginal surgeon. So with a little bit of saline infiltration, he's opening up the posterior pouch, placing the speculum. He is particularly holding the cervix with Alice to get a good grip rather than crushing it with a sponge holder. And then again, with the same infiltration, he's opening up the anterior pouch as well. And like in laparoscopy, he's just applying a suture, a higher up suture compared to the McDonald suture. He's going really pretty high up. And we could use the Foley's or something to push up the bulging membranes also. And once the stitch is placed with the Merceline tape, this is on one side, and then he's repeating it on the other side. Oh, sorry, I came out. He's tying it posteriorly. And the vagina is closed on both sides. Still, there is a role for pessary. I know most of us have been using Arabin pessary extensively nowadays because when there is a technical difficulty, when we are very afraid to do it after 24 weeks, it's very difficult to do laparoscopy. Arabin pessary still holds good. I think Aruna ma'am uses a lot of Arabin pessary. She was talking to us about the new innovation she's trying to do with the Arabin pessary. We were waiting for it, ma'am. Over to you, sir, for laparoscopic cerclage.
We already mentioned that abdominal cerclage is indicated when there is prior failed vaginal cerclage, or there is practically you cannot perform it vaginally because there is anomaly of the cervix or it has been deformed. I think and when to perform, if you look at the literature, 70% of them is being done as an interval procedure. And this is one meta-analysis where they have found the results are better than during pregnancy. I think we don't have time for two videos, so I will go directly into a cerclage laparoscopically we performed during pregnancy. This is one video I have presented in the American Journal where showing 6 steps. So this is the history, this ultrasound finding. And in pregnancy, it's always a challenge for the visibility as well as the chance for increased bleeding because of the vascularity. Normally, you cannot do any uterine manipulation. So what we do is you put your finger and push the uterus into the abdomen, and the first step is opening the UV fold. No instrument is used inside the vagina. You can use your hand to push the cervix so that you will get a space. As the uterus enlarges, probably this will become more difficult. This way I said it's 13 weeks. A harmonic comes, and we don't use any vasopressin or similar vasoconstrictors, being a pregnant uterus. And the UV fold is open. And the second step is we always make an opening in the broad ligament and make a window so that you can precisely take the suture medial to the uterine vessels. So you make a small incision with the harmonic, and you make the opening in the broad ligament, a window is made. So you can come from above, or you can push an instrument from below. And you have to be very gentle, as you know that there are large veins in the broad ligament. If you think that the window is not very clear, you can definitely make it bigger. Very precise, small steps to avoid damaging the veins and producing active bleeding. The next step is making a similar opening on the right side. I may need 2 more minutes to complete this video.
Yeah. Almost done.
You can open it widely if you think that your manipulation of the needle has to be seen perfectly. For an interval procedure, you don't need this because you can use a manipulator, uterus size is small, and you can precisely take. This is step 4. If anybody wants, this video is available on AIGL, American Journal of JMIC Journal. It's still available. The uterine artery and vein is visible. You take the bite medial to the vessel without injuring, and you should not encroach into the cervical canal. If it is still enlarged, an ultrasound guidance also can be used to avoid getting into the amniotic cavity. This is a muslin tape. As you know, there are 2 needles. So on the right side, the suture is taken. Now we come to the step 5, placing it on the right side. The muslin tape is encircling the cervix. And now you visualize the vessels before taking the... This is the main advantage of making a big window. You can precisely take the bite medial to the vessel. You clearly identify the artery and vein. Gently pull the... Thank you. Actually, posteriorly, if you see that it's above the arch of uterosacrals at this cervico-isthmus junction, make sure the tape is snugly fitting onto the cervix. Now both needles are cut for an easy tying of the knot. This is the last step. Tying is little clumsy because the tape is wider. So you need a standard is people put 5 to 6 throws. And the tightening is visual tightening. You can use the transvaginal ultrasound at this point if at all you want to have a precise placement. You put a step on the knot. The second throw. Normally 4 to 6 throws you can. Cut the extra length. Some people put another smaller stitch on the end of the tied knot. You can see the correct positioning. This is the correct placement. You need not close the peritoneum. If at all you want, you can, but I personally think that it's not needed. This was long back, she delivered and by cesarean. I will not go to all these details. To conclude, cervical insufficiency normally treated by vaginal cerclage, and a lap cerclage is indicated when for a failed vaginal or when the cervical cerclage is not possible. Interval cerclage is preferred, and there are many modifications, and usually elective cesarean is done at 37 to 39 weeks. And lap cerclage is a highly effective intervention for refractory cervical insufficiency. Thank you all for the patient attention.